So xerostomia, recognizing and treating dry mouth to improve patient outcomes. And thanks again to Dr. Jen. I am in the desert. I'm in Phoenix, Arizona. As you probably saw in the news, we had record temperatures this year, and certainly not conducive to salivary flow. But these are the educational objectives, and this is a view actually outside of our home here, our area that we live in Scottsdale. So we're going to understand and define xerostomia by the end of this presentation, be able to describe the oral anatomy and physiology related to salivary function, discuss composition, etiology, and epidemiology of saliva, determine a xerostomia diagnosis. How do we arrive at that? Recognize our at-risk populations, develop and prescribe short-term and long-term treatment options, and describe alternative non-pharmaceutical treatments. Why do we need to care about xerostomia? Well, we know that understanding xerostomia and its sequelae are essential in the proper diagnosis and treatment plan formulation for our patients. And when we look at this photo, what do we see here? We see root tips, we see a cracked, fissured tongue, we see dry lips, we see decay on the incisal edges and root caries. And this is very reminiscent of the many patients that I treated in our geriatric program and really in public health. We know that digestion is initiated in the oral cavity, and that requires healthy saliva. So mechanical digestion requires adequate saliva, both in flow and composition, so that we can form a bolus to swallow. And chemical digestion refers to the healthy composition of enzymes and antimicrobials and et cetera that we'll talk about required in the saliva so that we can initiate digestion and begin to metabolize protein, fats, and carbohydrates. So not having adequate salivary flow and not having saliva with a proper composition impacts our digestion. It impacts our ability to break down, initiate digestion. And so there are catastrophic consequences that occur when we don't care. And if we look at this patient, older adult, great smile, enjoying whole food, fresh vegetables, apples, etc. But we go to this slide, and this is an all too often scenario that I would see. I would get a call that Mrs. Smith, the physician, believes they may have dental problems and they're not eating, they're isolating in their room. Meal times are very much a social time, a social requirement for this population, I would say. And so the inability to initiate digestion when a patient might be on multiple medications, obviously this patient is probably edentulous in some form or another. When you cannot nourish yourself because of tooth loss and other issues, there are comorbidities that we need to be concerned about: dementia, fall risk, isolation, depression, frailty. Dental caries and catastrophic tooth loss is a problem that can lead to death. Untreated dental disease is linked to 1 in 10 deaths due to aspiration pneumonia in institutionalized adults. And so these patients I would call my Jello patients or the tapioca pudding patients. They're not sitting in the dining hall with their table mates. They're sitting in a room eating soft foods, Jello, etc., not able to nourish themselves. So identifying these at-risk populations and understanding the importance of treating xerostomia, it's linked to nutrition, morbidity, mortality, may save a life, or at the very least, improve the quality of life for many of our patients. So we have in this photo, of course, 2 older adults smiling, look fairly healthy and happy, and they're enjoying high quality proteins, vegetables, and so forth. Might not be my choice, but they're certainly not in the Jello line, right? So again, just to reiterate, our purpose really is to identify at-risk populations before they get to that slide that I showed you of root tips and so forth, and understand that xerostomia recognition and treating xerostomia is essential to overall health and well-being. Certainly, frail patients deserve the same oral health as the rest of us. And we want to try to avoid this at all costs because it's a slippery slope. You don't often turn around from frailty. In children, xerostomia, an increased risk of dental caries was linked to secondhand smoke. So if you have patients that are smokers, let them know that they could be putting their children at risk for dental decay because of a form of xerostomia that occurs. Diagnosing xerostomia can be a window to the patient's health and overall well-being. And let's go back to that slide. When we look at that slide on the left-hand side, what do we see? Depapillated tongue, right? Left-hand side, cracked, fissured, angry, dry, cracked lips. On the right-hand side, we see a pink, happy tongue. This is pretty extreme, but it does give you a very good example. And I will tell you, a couple of years ago, I had C. difficile from a dental procedure, and I became very malnourished. And I was also on multiple antibiotics that caused xerostomia and oral health lesions. It's really a miserable existence when you have severe xerostomia and your life depends on nourishing yourself and you can't because it's too painful or you don't have enough saliva to swallow it. And my tongue quickly turned to this left-hand side. I watched it. I took photos in action because I knew what was going on. And it returned to this side as I was able to nourish myself and no longer have to take oral vancomycin, fidaxomicin, and so forth. All right, what about the diabetes patient and xerostomia? Signs and symptoms of xerostomia are often associated with other conditions or diseases, and diabetes is one of those. This is a patient with poor blood glucose control and developed pseudomembranous candidiasis. Sjogren's patients, this is probably the most famous demonstration of xerostomia, right? It's a triad. Sjogren's syndrome is a triad. It also affects the lacrimal glands and the ability to secrete saliva or tears. And in that patient, what do you see? Cracked, fissured, angry-looking tongue. And certainly in this photo as well. So xerostomia is defined as a subjective sensation of oral dryness. It's what the patient's telling you. And if they're telling you they experience dry mouth, believe them. If we look in their mouth and say, well, you know, geez, they look like they have plenty of saliva, let's just keep an eye on it. We could be watching something that leads to catastrophe. Older adults sometimes will transition from different levels of care. If we're seeing them in the dental chair and they're telling us that they have dry mouth, no harm, no foul in treating it, or at least preventing the catastrophic consequences that occur if we ignore it. So it is a subjective sensation. It may or may not be associated with a reduction in salivary output. It can also be an issue with quality versus quantity, or it could be both, right? So although you hear xerostomia used interchangeably for dry mouth, it can also be a situation where the components of the saliva itself, there's something missing or something being affected that could be caused by medication, for instance, right? So although we commonly connect the term xerostomia with dry mouth, it could be a term used for an issue with quality. It may not be healthy saliva. Something's missing or some things may be missing. So the composition has changed. And you've seen this in patients, right? The ropey saliva, the stringy saliva, the saliva that follows your saliva ejector. That's not healthy saliva or foamy saliva, right? When you look at this patient, what do you see? You see oral candidiasis on the palate. You see some sort of ulceration at the junction of the hard palate and soft palate. A coated tongue. I suspect they're probably a tobacco user as well. A lot of staining and erosion. And this is very reminiscent of what our AIDS patients looked like in the 1990s when I was at UCSF. They presented like this quite often. So xerostomia is not a disease, it's a condition. It's often a symptom of a disease or multiple diseases, and it can produce serious negative effects. It can affect nutritional status. It can alter dietary habits, as we saw early on. It's difficult to swallow. It's difficult to chew. It can affect your speech, your taste. It can impact dental prostheses. Dentures are meant to rest on moist tissue. When tissue is dry, it is problematic. Increased risk for rampant dental caries as well. I was treated for some vertigo a few years ago, and I was given some medications to help with the vertigo and the nausea. The typical stuff, scopolamine, meclizine, Zofran for the nausea, right? One of those is enough to dry up your saliva, but I was sitting in the emergency room and my saliva dried up to the point where I couldn't speak. I sounded like Daffy Duck. And the emergency room doctor came in and they wanted to work me up for a stroke. So no, I could talk fine. It's the medication. Sometimes the physicians, it does not occur to them that the medication they're prescribing has this effect, right? And we see this in many of these facilities, and this is one. This was actually one of my patients. And she entered a facility, a residential care facility in Surprise, Arizona, which happens to be in the news right now, but that's another story. She had all of her dentition. This is what happens with xerostomia. Now, you're going to look and you say, well, geez, her tongue looks moist. I see a little bit of saliva here. Trust me, this was xerostomia, and this is what happens when the medical staff doesn't realize that the medications they've prescribed are xerostomic, and the staff, the medical staff, nursing and so forth, there is no oral hygiene in place. There is no scheduled dental visits, although gosh knows the foot doctor's there, the hairstylists are there, the bingo games are occurring on Friday, but the dentist can't get in there. This is the age-old issue that we have, at least here in Arizona, and I suspect it's probably widespread across the US. So this patient suffered. Now, this was not that long of a situation. This was maybe a year and a half, 2 years that the patient had been in the facility, and we get a call, Mrs. Jones fractured a tooth. She's missing a front tooth. Oh my gosh, you got to get here today, or we're going to find another dentist. Now, the fact is, that's a 5-alarm fire for them. If it's a back tooth that fractures, it's not an issue. But when it's an anterior tooth, the families are going to see this, right? And then the families are going to want to know, what happened with my sister or my mother or my husband? We thought they were going to get good care at this facility. Have they not seen a dentist? Is nobody brushing their teeth? And then we have to give them the bad news, right? Okay, so xerostomia affects 25% of the population. It's becoming one of the fastest growing oral health problems in North America, and it's becoming increasingly common in developed countries because we live longer and we have more medications available. Medications are the cause of more than 90% of xerostomia cases. Estimated over 500 different medications contribute, and there are certainly synergistic effects between some of these medications, particularly for older adults, and we call that polypharmacy. 32 million Americans today take 3 or more medications daily. If you hear your patients say, I'm on these 3 medications, there should be a little bell that goes off, ding, 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 ding. I might want to put them on some preventive therapy in case they are developing xerostomia. They may not recognize it. They may tell you that they have plenty of saliva, and then you look during your evaluation and you see that the buccal surface of 30 and 31 is completely wiped out. And then you look on the other side and you see the buccal surface of 30, 31 and adjacent completely wiped out. What's going on? You ask the patient, are you using any sort of Medications, are you holding anything? Oh, yeah, I get a dry throat. Sometimes I get this little tickle in my throat, and so I use cough drops, and I just hold it there, and it helps calm that down. They're actually describing to you in many cases xerostomia, but they don't realize that it is inadequate salivary flow. They don't realize it's something that we can help them treat. So it's always important to ask every patient, do you have enough saliva? And if they say no, ask them what they're doing to self-treat. If they tell you they're sipping on Orange Crush at 3 in the morning, we need a different strategy, right? And they'll tell you, oftentimes they are doing something like that because they don't understand the situation. So it's up to us to identify and educate it. Now, we could reduce the risk here, or the effects, excuse me, of xerostomia by replacing one or more of these medications. Sounds like a really sound, practical approach. Is it practical? No, it's not in most cases. Why? Because many of these patients that are on these medications that are stabilized, the physician is going to be less likely to start playing around with these medications because the poor patient doesn't have enough saliva. They don't see the efficacy at putting that patient at risk, especially if it's a behavioral health patient or dementia patient or all of the above. They're not going to move around and play a shell game with medications because of salivary flow, right? So it's up to us to identify it and treat it. And of course, xerostomia, not a great problem in the past because we didn't take as many medications as we do today. We described that xerogenic drugs are found across 500 or more medications, 42 drug categories, 56 subcategories. I defy you to find a patient who does not walk in during the day taking at least one of these, especially during allergy season. And they're here: anxiolytics, decongestants, antiemetics, antidiarrheals, bronchodilators, etc. If they're not on these medications for life, then once they stop taking the medication, the salivary flow should come back to its normal pre-xerostomia days. But if they're on these medications for life, it may be a lifelong affliction for them that we have to address. Right. I would never ask a medical provider to actually, they're just going to laugh at you anyways. So if you have an older adult on 23, 26 different medications, and you call up the hospital staff and say, hey, you know, your patient has dry mouth, can we replace this antidepressant? That's not going to happen. So we have to treat it, right? Why would a patient be on medication for life? For diseases or conditions or mental health issues, they may be on medication for a lifetime. If you require thyroid hormone, that is a lifetime replacement usually. Sometimes patients are on heart medications for the rest of their life, right? All right. So always carefully review the medications with your patient. Sometimes they're going to whip out the Dead Sea Scroll of medications. I call it the Unabomber's Manifesto, where they've carefully written down every medication for you, which is great, right? But when they get to about number 3, I just tell myself, okay, xerostomia regimen, time for education, frequent evaluations, and we're going to put them on some prevention. How often do young people suffer xerostomia? They do, especially if they're on behavioral health medications or they're vaping. Treatment of drug-induced xerostomia, again, it may be possible to change the medications around, but it's highly unlikely that that's going to occur. And symptoms of xerostomia are often worse between meals at night and in the morning, nighttime, because the parotid gland shuts down. Sometimes you can consider modifying the drug schedule so that that peak plasma level occurs when the patient's awake. That's important for your older adults because they might require assistance to go to the restroom at night, or they're using a bedpan. The thing is that for you all educating your patients, it's not a good idea to just automatically tell the patient you need to sip water at night. They might be a fall risk, and we don't practice in a siloed situation. We have to communicate with their other medical providers. They might be on fluid restriction. They may have congestive heart failure, etc. So we have to talk to their other medical providers and come up with a plan. If the patient's being affected by this, both mentally and physically, it's a good idea for all of their providers to get together and come up with a treatment plan, right? Further considerations on drug management: certainly easy to take formulations. Many of these patients have a hard time swallowing capsules or pills. They may need a sublingual dosage if it's available. The pharmacist can counsel your patient on what medications may or may not be crushed. They should first lubricate their mouth with a full glass of water, and then follow up with more water, unless, again, they're on a fluid restriction. Again, we can talk about maybe switching medications with less anticholinergic activity, but it's highly unlikely that that's going to occur. Let's talk about anatomy and physiology. There was a question about Adderall. Adderall can cause xerostomia, and certainly medications that are for behavioral health, etc., can as well. Even your children that may be treated for allergies, allergy medications and decongestants, although it might be temporary, can cause xerostomia. All right, so we're going to talk about anatomy and physiology here. What do we need to know? Well, oral glandular tissue begins about 6 weeks, and it will be completed around the 12th week, and then those glands will just continue to enlarge until birth. Saliva, defined as the viscous, clear, watery fluid secreted from the parotid, submaxillary, sublingual, and small mucous glands of the mouth. I call it a substance that you take for granted until you do not have enough, and it's one of the most miserable conditions you could even hope to ever not live through. So when your patient, again, is experiencing this, it's a good idea to be in their shoes and help them feel better. All right, what do we know about the properties of saliva? Going back here, we're going to be talking about the glands and how they're classified momentarily here. But the properties of saliva: the pH of saliva falls between 6 and 7.4. It contains a large amount of potassium and bicarbonate ions, to a lesser extent sodium and chloride ions as a buffer. Saliva also contains various antimicrobial constituents, enzymes, immunoglobulins, and so forth that will break down also. Purpose is to moisturize, cleanse, lubricate, as we said, initiate digestion, dentition, remineralization. We're going to be talking about ways to help the patient remineralize here towards the end. You're going to have Adam Van Sickle join me after my presentation to talk about the properties of nano-hydroxyapatite. Mucosal integrity, immunity mediator, antimicrobial. The large glands, the major glands, stimulate the minor salivary glands. So if the major glands are affected, eventually the minor salivary glands may be affected as well. Cellular maintenance, swallowing, taste, and speech articulation. So we classify glands 3 ways: by the type of secretion, the major or minor gland, and then the innervation, whether there's a parasympathetic or sympathetic innervation. So we talk about secretion first. Salivary glands can secrete either a serous, mucus, or mixed secretion. Serous is the very thin and watery secretion secreted by the parotid and lingual glands. The mucus secretion is the very thick and viscous secretion secreted by the palatine, posterior lingual, and buccal glands. And then a mixed secretion, a mixture of the two: sublingual, submandibular, and anterior lingual glands. So the salivary glands, when we classify by major and minor, The major glands secrete intermittently and the minor glands secrete continuously. So the minor glands are the mucosal glands. They're there to protect and lubricate the mucosa and protect the integrity of the mucosa. So they secrete all the time, but the major glands secrete on cue. If you're having pizza, etc., that can cause you to salivate, right? So the parotid glands, let's break down the major glands. They're the larger of the three major glands, producing 30% of the total saliva output. We all know about Stenson's duct, and innervated by the sympathetic and parasympathetic divisions, and it secretes a serous-type saliva. The submandibular gland is the second largest major gland, producing 65 to 70% of total saliva output. We all heard of Wharton's duct. It is innervated by parasympathetic nerve endings, possesses no sympathetic receptors, and it is a mixed secretion, mostly serous. And then the sublingual gland, mostly mucus, smallest of the major glands, produces less than 5% of total saliva output. We've heard of the ducts of Bartholin, another board question. Innervated by parasympathetic fibers, little or no sympathetic influence. And again, mixed secretion, but mostly mucus. And then the minor glands. The minor glands secrete continuously, as I said. So they're found throughout the oral cavity, the lips, the buccal mucosa, the alveolar mucosa, the dorsal and ventral aspects of the tongue, and the floor of the mouth. Now, innervation is the third way we classify these glands, either sympathetic or parasympathetic. So sympathetic innervation is responsible for the dry, thick, ropey saliva. The parasympathetic innervation is responsible for the thin, profuse saliva. And these can work in opposition and can influence the quantity and the quality of saliva. All right, epidemiology, etiology of xerostomia. If you have any questions, please type them into the chat area. For those of you who logged in a little late, you're going to need the CE credit instructions and a copy of these handouts. Tap on the red banner at the top of the screen or check your email. Be sure to be here for the passcode. You'll need it to verify your attendance. All right, the normal daily production of saliva varies between 0.5 and 1.5 liters. The whole unstimulated flow rate is approximately 0.3 to 0.4 mils per minute. Unstimulated flow, that is resting salivary flow with no external stimulus. This rate decreases to 0.1 mils per minute during sleep because the parotid gland shuts down. Less than 0.7 mils per liter, mils per minute, is considered hyposalivation. And the normal stimulated salivary flow rate averages 1.5 to 2.0 mils per minute. So then stimulated flow is a response to stimulus, and our major glands are secrete intermittently according to stimulation, but our minor glands do not. They're stimulated all the time, and a feedback from those major glands as well. So if the major glands shut down, eventually the minor glands could shut down as well. All right, salivary flow peaks in the afternoon. It decreases at night when the parotid gland shuts down. And 90% of saliva is water, 10% inorganic and organic ions and cellular components. Sodium, potassium, and calcium are positive ions. Those are cations. Chloride, bicarbonate, and phosphates are negative ions, anions. That is going to be important for you to understand how fluoride works. I learned something new this year from Dr. Jennifer Eisenhuth at Dr. Jen's, and that is when you have a patient with xerostomia and you are trying to use fluoride, it's probably not going to work as well because they don't have enough ions to help transport it. And we'll talk about that to effectively remineralize the dentition. So it's these cation, ionic, and anionic components that play a critical role in the function of saliva. Saliva passes through the salivary ducts, and these cations are reabsorbed into the adjacent blood vessels. And in exchange, the bicarbonates and the potassium are transferred from the blood vessels into the salivary duct, and this is how we create salivary flow. So there are various enzymes that we need to be concerned about, because these enzymes can either prevent bacterial infection or initiate digestion. Amylase, specifically ptyalin in the saliva, converts starch into glucose and fructose. We have lysozymes. It's an antibacterial. Histatins prevent fungal infection, also antimicrobial. Secretory IgA is an immunity mediator. Lactoperoxidase stimulates the minor salivary glands, as we said, RNase, DNase, for cellular maintenance. Lipase initiates the digestion of fat in the oral cavity. Kallikrein, a vasoreactive substance, and stadherin. So stadherin is an important protein that inhibits the precipitation of calcium phosphate in saliva, and it permits the remineralization of enamel and high phosphate levels for buffering. Also, cellular composition, epithelial cells, neutrophils, lymphocytes, bacteria, flora. I've had a patient tell me sometimes when she eats that she produces so much saliva, her parotid glands hurt. Is that real? It can be. I don't know if it's hurt necessarily, but they could be describing pain. Sometimes that can occur with citrus fruits too, but that is a phenomenon that can occur. Okay, factors that affect salivary flow. COVID-19 is one, and there were a couple of studies, actually multiple studies, but I have a couple identified here, where dry mouth appeared as early as 3 to 4 days before other symptoms. So it appeared as a prodromal symptom. Now, that doesn't mean that the next patient that tells you they have dry mouth is COVID, all right? That's a differential diagnosis that we have to rule out. Another study here, 32% of COVID-19 patients reported signs of xerostomia, and it preceded their symptoms. Autoimmune diseases, Sjogren's, probably the most common autoimmune disease. Lupus is another. Systemic diseases, asthma, sarcoidosis, diabetes, kidney, renal failure, HIV. This was a study where it wasn't a large study, but 57 patients that were treated with inhaled corticosteroids for bronchial asthma. And you know, if you have patients that are on corticosteroids, corticosteroid inhalers, what are they told to do after they use it? They're told to rinse with water. Rinsing with water may not do enough, especially if the patients are also on systemic cortisone or prednisone. So they develop candida infections. Now, in this case, they wanted to look at a cross-sectional observational study where they used a xerostomia inventory test in the degree of asthma control. And 40 patients had asthma, 17 did not. In the asthmatic group, patients with uncontrolled asthma had worse xerostomia inventory test scores than those with partially or totally controlled asthma. So it's determined there is a moderate relationship between the degree of asthma control and severity of xerostomia. I've seen this in patients with COPD too, especially patients with COPD and a history of tobacco use. All right, sarcoidosis is a disease that causes inflammation. Causes inflammation of various organs, lymph nodes, skin. Unknown what causes it, but thought to be environmental triggers, dust, chemicals, or a bacterial or viral infection. It may have a genetic predilection, and xerostomia can be a symptom. Diabetes, as we said, salivary stadherin is compromised in uncontrolled diabetic patients. So you may see more frequent dental caries in these patients, right? Kidney disease, renal failure, salivary gland disease here. Studies have shown that 40% of more people or more of people with HIV experience major xerostomia during the disease course, all right? And it can negatively impact their lives. Now, I certainly saw my fair share of HIV patients at UCSF in the 1990s, and that's very true. And oftentimes it was the parotid gland that was involved. It can also be the medications that they're taking or both. Additional factors can be psychogenic, also radiation therapy, certainly. Sometimes the gland can still produce some saliva, so the fibrosis caused by the radiation therapy didn't completely wipe out the gland. In other cases, the gland may be completely fibrotic and can no longer produce saliva. In the case where there is possible tissue that is remaining, there are some technologies that can be used and some medications that may be able to squeeze out more saliva out of those glands. Gender, usually women 70% postmenopausal, and there's a study there for you to look at. And they found in menopausal women, they may not have complained about xerostomia, although upon being tested in this particular study, they definitely had reduced salivary flow. And of course, we have patients that are postmenopausal or perimenopausal that develop burning mouth syndrome and so forth. So food for thought. Parkinson's disease. This was a study, dry mouth, an often overlooked autonomic symptom of Parkinson's disease. And what they found here, that dry mouth was reported by 60.8% of this study, and dry mouth and drooling existed in 30% of their cases. Only 12% of the patients, though, had reported dry mouth to their physicians. Additional factors, circadian rhythm, decreases in the fall, it increases flow in the spring. Age, you might see this on a quiz. Studies show that among non-institutionalized older adults not taking medication, neither the quantity or the quality of saliva changed significantly with age. So aging may cause other undesirable effects, but it didn't impact the structures or the function of the salivary glands. However, as we get older, we may be taking more medications, and it might therefore be impacting salivary gland flow or composition. Studies show a positive correlation between the number of drugs taken and the incidence and severity. All right, how do we develop a xerostomia diagnosis? Your patients may complain of eating, speaking, swallowing, wearing their dentures. Dry, crumbly foods may be difficult for them to eat and swallow. Denture wearers may have issues retaining their dentures, or they're developing denture sores. Patients with xerostomia may complain of taste disorder or a painful tongue or an increased need to drink water or something at night. And as we said, xerostomia can lead to catastrophic tooth loss, dental caries, parotid gland enlargement, inflammation, fissuring of the lips, inflammation or ulcerations of the tongue, the buccal mucosa, oral candidiasis, salivary gland infection, halitosis, and cracking and fissuring of the oral mucosas. So diagnosis of xerostomia: review the patient's health history, examine the oral cavity. We should consider xerostomia if the patient tells us they're experiencing dry mouth, or it may be too late and they're already developing cervical decay. At that point, we have to treat the caries or treat the tooth loss and deploy perhaps temporary reline of existing dentures to evaluate to see if those need to be relined or refabricated. If they are describing difficulty eating dry foods or high quality proteins, that should be a 5-alarm fire. All right. When the mouth is examined, a tongue depressor may stick to the buccal mucosa. This is one from the textbook here. In women, the lipstick sign, where lipstick adheres to the front teeth, may be a useful indicator of xerostomia. I'm here to tell you, I've not noticed that myself, but I was also told in dental school I'd be a better dentist because I wear makeup and I could see upside down in a mirror. So I'm not sure if that has real validity or not. I've seen plenty of lipstick stuck to anterior teeth and the patient didn't have xerostomia, but I like to include that. I think it's kind of interesting. All right, oral mucosa may be dry and sticky. You may see candida infection, pseudomembranous candidiasis. As we said, the saliva might be stringy, ropey, or foamy. We may see dental caries around the cervical margins or the incisal margins or tips of the teeth. There are tests available to diagnose xerostomia as well, but I can tell you for your patients that are on medications, the tests are going to just all take you to the right place, which is we have to treat it, right? If they're telling you they have dry mouth and they don't have a history of radiation therapy or any of the diseases or conditions we were talking about, then we have to treat it. And we have to prevent the sequelae that can happen, catastrophic tooth loss. We have to recognize it, educate the patients. But in the case of patients that may have had Sjogren's, or they have had surgery, or they've had radiation therapy, oftentimes these tests will be deployed, and the patients that may have some sort of tumor or obstruction, right? So this is a breakdown of some of these diagnostic tests that are available. Sclerography, which is imaging, also used to identify obstructions, masses, stones. Salivary scintigraphy will assess salivary gland function, rate of flow, density of uptake. Minor salivary gland biopsy also to identify patients perhaps with Sjogren's syndrome, HIV, associated salivary gland disease, sarcoidosis, amyloidosis, and biopsy of the major salivary glands is an option when malignancy is suspected. It's important to recognize at-risk populations. Certainly, we said our patients, polypharmacy is the number one. Our older patients, again, are at risk. It's not predictive. Just growing old doesn't mean our salivary glands are falling apart. But it means that we might be on medications or we may have other conditions. Our behavioral health patients, certainly because of the medications, and our special needs patients are high risk for xerostomia. I think if this is identified from the get-go, you just have to deploy any prevention that you can and make it an automatic diagnosis, because the medications just lead to that, and oftentimes the hygiene is not there and the care may not be there. All right, we spoke about symptoms earlier, but good review: viscous saliva, sticky saliva, difficulty speaking or swallowing, halitosis, altered taste, complaint of dryness or burning mouth, altered sense of smell, frothy saliva, gingivitis, absence of saliva, cracking and fissuring of the mucosa, or food actually still stuck to the teeth. Signs here: increased caries, frothy saliva, gingivitis, absence of saliva, as we said, ulceration, no pulling of saliva in the floor of the mouth, recurrent candida infections, toothbrush, mouth mirror, instruments may stick to the inside mucosa of the tongue as well, and poorly fitting prostheses. This is a case by our colleagues here, Mobile Dentistry of Arizona, and I want to give a shout out to Ann Ross, who's the owner. She's a hygienist here for many years. Excellent program. And this was one of their patients from a skilled nursing facility in Prescott. And by the way, these photos were used by National Public Radio when they interviewed us. This was a patient that entered a facility with all of their dentition, and this is what happens because of xerostomia. Now, the problem here is that many of these patients invested in their dentistry their entire lives. This was a bridge. There was an upper partial denture that abutted to all of this. Removing these root tips, you're going to have to expect perhaps delayed healing, because these patients are malnourished. There is no way this patient is well nourished. No way, right? So we have to have a conference with the medical team, let them know what we're going to do. And if we fabricate dentures, hope that they're able to actually use them and find them a week later, right? In some cases, if this is a patient who doesn't have memory issues, etc., they're a good candidate for implants, as long as they have someone available to care for them, because now they're going to be able to eat and function, right? So we have to carefully assess the patient. Develop and prescribe short-term and long-term treatment options. Over-the-counter products with moisturizers like xylitol is very good for these patients. And they're not drinking it, they're rinsing with it, or they're brushing with it. Advise the use of sugar-free products only. Certainly fluoride can be applied, but understand fluoride requires healthy saliva to remineralize, and you'll see this shortly here. Try to determine the cause. In some cases, we can reduce the catastrophic tooth loss. All right, for fluoride to be effective in remineralizing the dentition, it requires calcium and phosphate in healthy saliva. So saliva contains many important substances, and it acts as a transporter of the many ions, such as calcium, phosphate, and fluoride, that are essential for the promotion of remineralization. If not fluoride, what? Well, nano-hydroxyapatite can act as a remineralizing agent, but it has to be at an optimal concentration, and it doesn't require the presence of calcium phosphate. And you'll hear our colleague here, Adam, if you choose to stay afterwards, and I hope you will for a few minutes, talk to you about this. So nano-hydroxyapatite acts as a calcium phosphate reservoir. It keeps a state of supersaturation with regard to enamel minerals. It enhances remineralization and inhibits demineralization. And there's some studies for you and research all points that you need 10% as the optimal concentration for remineralizing incipient carious lesions. How to manage these patients: symptoms should be noted and signs recognized to properly diagnose. The goal overall is we want to try to increase salivary flow when possible, but it's not always possible, as we said. There are drugs available that can mimic or stimulate the parasympathetic division of the autonomic nervous system. They aren't for everyone. There are side effects, but they can be used in patients that have some salivary tissue left, perhaps Sjogren's syndrome, or patients that have had radiation therapy. Sugar-free lozenges can be used, but we have to be careful with anything with citric acids, right? Saliva substitutes and over-the-counter products for medically induced or salivary gland hypofunction. Oral hygiene at least 4 times a day after meals and before bed. Fluoridated toothpaste, but I'm going to bump that up and say consider nano-hydroxyapatite or nano-hydroxyapatite in conjunction with a fluoride dentifrice that Adam will talk to you about. You can also have them rinsed with a baking soda solution, a teaspoon of baking soda and 8 ounces of water 4 to 6 times daily to try to neutralize the acids. Avoid citrus. Rinse and wipe the oral cavity immediately and keep water handy as an oral moisturizer. Avoid sugar in your foods. Avoid alcohol and salty foods. Brush and rinse those dentures after meals. Use a nano-hydroxyapatite toothpaste at an optimal concentration. And you can use a fluoridated or fluoride gel at bedtime. But again, if the patient's lacking saliva, that may not be the best choice. Fluoride varnish, moisturizers on the lips, saliva substitutes, antifungal treatment is required, and reevaluate denture patients for optimal adaptation and fit, and monitor for denture stomatitis. What I do with my xerostomia patients that wear dentures, first of all, we clean and soak those dentures in sodium hypochlorite solution. And then I use a temporary reline, and I'm going to visit that patient on a weekly basis as we treat their xerostomia. I'm also, if it's long-standing xerostomia, like some of the cases I showed you, I put them on an antifungal rinse, nystatin. Because if we don't address the fungal infection that may be in the glands, then we're not going to be able to adequately treat the patient, right? If the dentures are haven't been cared for in some time, we have to address all of this. Once we do these weekly relines, we can then reevaluate the patient for vertical dimension and find out, can we actually reline this denture, or do we need to refabricate the denture, right? I know that nystatin contains sucrose, but it's a risk versus benefit. If you see these patients and they're not able to nourish themselves, clotrimazole lozenges or troches are not going to work in this patient population. In fact, they can be a choking hazard because they're not going to be able to melt those in their mouth. So have them use a rinse. It's just easier. The dentures do not adapt very well to dry mucosa, right? So you have issues with denture sores and so forth. Fungal infections. Some of these patients are predisposed to candidiasis because of the lack of salivary histatins. So again, recommend an antifungal medication. And this is a breakdown of treatment recommendations. So oral candidiasis, certainly nystatin, rinse. There are antifungal ointments that they can use in the marionette lines. And if you can get rid of the angular chylosis caused by the xerostomia, and you can very quickly, especially if you address the fungal infection, you're going to be their hero because that is a very painful condition. All right. For bacterial infections, systemic antibiotic therapy may be required. You want to increase hydration and stimulate saliva with either minced lozenges. Sometimes gums are not going to work well for these patients. But note, the American Dental Association no longer recommends clindamycin for antibiotic prophylaxis. It was removed from the guidelines as of 2019 and 2021 due to the risk of Clostridium difficile infection and dentists being sued. So if you are still using clindamycin, if you tap on that link, it will take you to the ADA's updated recommendations. But you need to eliminate clindamycin from your formulary. And it doesn't matter if you're dealing with an older adult or a younger adult, clindamycin should not be in anybody's dental practice. All right. Poorly fitting prostheses, soft and hard tissue relines, as I described earlier. They may be using denture adhesives just to get them through this treatment phase. Dental caries, fluoridated dentifrice. We're going to talk about nano-hydroxyapatite here. Dry mouth, plenty of over-the-counter remedies that they can use, rinses, sprays, gels, etc. There are medications, pilocarpine, for instance, cevimeline. Now, both of those do have side effects. Drinking of fluids while eating, and for patients that can't taste their food very well or they can't swallow very well. Careful eating with fluids. And again, you want to check with the hospital staff or their medical staff to ensure that they can have all those fluids. They may have to stay away from dry, hard, crumbly foods for a while. This was something that was just published today. I won't be giving you the passcode until I'm done, so just hang on. You've got 2 minutes. Knox Lab explores the key to repairing damaged salivary glands. I thought it was interesting if you tap on this link. This is Dr. Sarah Knox at UCSF, and they're developing a hydrogel that can be injected into damaged salivary glands in order to stimulate the growth of new tissue. And they want to try to restore these patients to capture their quality of life again, improve their quality of life. Photobiomodulation, if you are not familiar, take a look at this. This is a technology you can use now in LED. You can use your laser, and it will also stimulate saliva in patients that have some tissue left. It may not be 100%, and it's also been used in dentistry for many, many years. Go to the Academy of Laser Dentistry's website. They have a standard level certification course that you can learn about this, and the patient can take the devices home. So there are many studies that show the efficacy of photobiomodulation to treat these patients. There's more resources for you. I'm going to be introducing Adam to you here shortly. I'm going to put the code up on the screen. I haven't posted questions because it's moderated, so we're going to go through these. How can I test my saliva to know what it's made of? You can contact any of these salivary testing companies. They can help you. I can't really help you with your CPAP machine, but your physician and your nurse practitioner should be able to help you. And there are moisturizers available to you. What are the supplements for saliva? Are you talking about vitamins? I don't recommend Vaseline for these patients. because you don't want them to aspirate Vaseline. There is a course on our website, Nano-hydroxyapatite, that's presented, that Adam actually presents. So if you want to know more about nano-hydroxyapatite, the link is right here and it's clickable from your handout. I am really excited to introduce you all to Adam, because Adam knows much more about nano-hydroxyapatite than I ever will in my lifetime. Adam is a practicing dental hygienist and accomplished educator affiliated with Dr. Jen Oral Care, and they are the producers of nano-hydroxyapatite toothpaste. Adam has delivered lectures to hundreds of dental offices, captivating audiences with his expertise in the science of nano-hydroxyapatite. His educational outreach extends to dental hygiene programs. He imparts his knowledge to aspiring students. His publications and so forth have been everywhere, but he has won first place for his lecture on nano-hydroxyapatite at San Juan College Scientific Conference, for instance, table clinic sessions. He's a research librarian with a master's in library science and a dental hygienist. So welcome today, and thank you for being here, Adam. And I want to tell everybody, if you are using nano-hydroxyapatite right now, there are some things you should be aware of: the concentration, the efficacy, the safety. And we've got Adam here to break that all down for you. So Adam, take it away. Thanks.
Great. Thank you so much, Dr. Kroling. I appreciate the intro, and also thank you so much for this presentation. You do such a great job at bringing us into the shoes of these patients that are suffering from xerostomia. I'm really excited to talk to you guys about Dr. Jen's products and how they can really address xerostomia for these patients that are suffering. It is copyrighted. I work with Dr. Jen Oral Care with Dr. Jen. I am a registered dental hygienist, as Dr. Kroling mentioned. And Dr. Jen is an actual doctor. She's a dentist in St. Paul, Minnesota. She's been practicing there for over 25 years. And now she's actually considered one of the nation's leading experts on nano-hydroxyapatite. She didn't always have the goal of making toothpaste, but it was her daughter, Claudia, here that she's holding in this picture from 1996 that really was the inspiration for their brand. They had a life event. Claudia got sick. She contracted a severe gut bacterial infection called C. diff, and she was hospitalized for 3 days at the Mayo Clinic. And when she got out of the hospital, her physician, recognizing that her gut microbiome is connected to the oral cavity, suggested that she take a closer look at the toothpaste she was using. She'd always been using fluoride, but when she looked at the other ingredients that were in her toothpaste, and Dr. Jen as well, they were very surprised by the ingredients that were in there. Things like sodium lauryl sulfate, it's a foaming agent, but we know that it can lead to aphthous ulcers and impaired tissue healing, gingival inflammation. Titanium dioxide's actually been banned in Europe. Propylene glycol is a main ingredient in antifreeze. It's a humectant in toothpaste, but it can cause systemic issues. And then any kind of petroleum-based artificial coloring and flavoring, and really the list goes on from there. But the other requirement there that was really important for Dr. Jen to have for her daughter Claudia was an effective remineralizing ingredient. So she went online, and like all of us do, and started doing some research for some products in the US. And what she found was, while if they didn't have some of these toxic ingredients, they also weren't following the parameters around nano-hydroxyapatite. She discovered nano-hydroxyapatite online, but she found out that she's a researcher at heart, that there is an optimal concentration. And so she contacted a German chemist, an expert on nano-hydroxyapatite. In our country, we just didn't have any experts at the time. And so she worked for 2 years to develop Dr. Jen's line of products. But I wanted to set the stage a little bit for why it was so important to Dr. Jen to actually have a remineralizing ingredient in her toothpaste. It has to do with plaque, or this imbalance of bacteria, these streptococcal mutant bacteria that excrete acid and the like. And what they can do is influence the pH of the enamel, as you guys already know. Once that enamel gets down to a 5.5 critical pH, that's when we start to lose minerals from the tooth. The minerals that we lose in that demineralization process are calcium and phosphate. That happens almost every time we eat. Basically, our teeth get an acid attack. Uh, Fortunately, though, the body has created an ingenious system to combat that demineralization, and that is saliva. So for those people that have adequate saliva flows, they're going to get not only bicarbonate and chloride that raise the pH and bring it back up to neutral, but they also have calcium and phosphate that remineralize the tooth surface. Unfortunately, though, we live in a society where a lot of us are eating a Western American diet. We're constantly snacking. We're eating a lot of processed foods that are highly acidic. And so saliva just can't keep up. It can't do what it was designed to do on its own. And so the traditional approach to having a remineralizing ingredient to combat that calcium and phosphate deficiency essentially is fluoride. And fluoride, just a snippet about how it works, it is negatively charged and it creates fluorapatite when it gets introduced into the mouth. And it makes the teeth more acid resistant because it is dense. So that density allows it to be resistant against that demineralization. Interestingly, though, well, I should back up and say it also, because it's negatively charged, allows those calcium and phosphate ions from the saliva to draw in from the saliva into the tooth surface. However, what we're learning is that there is a biochemistry with fluoride that often doesn't get talked about. And this is a 2013 study that demonstrates that for every 2 fluoride ions, 10 calcium ions and 6 phosphate ions are required to form 1 unit cell of fluorapatite. So in order for us to get fluorapatite, we need saliva, and we need the specifically the calcium and phosphate that is within that saliva. Not only that, but in order to create remineralization, we're also dependent on that saliva. Fluoride is dependent on that saliva. This is a 2018 study also found on PubMed that says that fluorides require calcium and phosphate ions from saliva to improve the natural remineralization process. So, and then again, for xerostomia patients, oral care products with the addition of calcium and phosphate are recommended in order to compensate a calcium and phosphate deficiency. So the standard approach has been high levels of fluoride, but really we really need to start asking the question, given what we now know about the biochemistry of fluoride, is high levels of fluoride enough, particularly for these patients that have a calcium and phosphate deficiency? And I would venture to say that it does not, because those patients are not getting the fluorapatite crystals and they're not getting the optimal levels of remineralization. So that's where nano-hydroxyapatite can come in and really save the day. So what is nano-hydroxyapatite? It is the same composition of our teeth. It's calcium, phosphate, oxygen, and hydrogen, at least 97% of them, of our teeth. And it's also in the same shape. So it really is this superior product or ingredient that the body recognizes as self. The fluoride recognizes as self. It's going to utilize it. It's biomimetic. It's biocompatible. There is not an inflammatory response with nano-hydroxyapatite, and it's non-toxic if it's in the rod-shaped particles. How does it work in the mouth with specifically toothpaste? First thing that's going to happen is it's going to reduce the amount of Streptococcus mutant counts. It does that by adhering to the proteins in the bacteria, and it can reduce the amount of acid in the mouth. So it can help and reduce demineralization levels. Second thing is it helps remineralize the outer surface and provide a protective shield over the tooth, preventing stain and plaque from adhering to the tooth. And then it provided it's in the nanoparticle sizes, can remineralize the subsurface lesions of the enamel as well. Unfortunately, though, nano-hydroxyapatite, even though it has a long history, it's been around since 2003, been utilized in Europe and Japan and South America, even Canada. It is not regulated in our country. And so you see, unfortunately, companies that are putting in ineffective particle sizes of hydroxyapatite or microhydroxyapatite. And unfortunately, those crystal particles are unable to integrate into the subsurface lesions. Likewise, if it is in the nanoparticle, it is small enough to occlude the dental tubules, relieving hypersensitivity as well. Not only that, but it can address root caries for our patients that are suffering from any kind of recession and root caries. It is demonstrated to do all of those key factors, provided it's in the optimal concentration. As Dr. Kroling said, concentration is key with nano-hydroxyapatite. There is a sweet spot. This is a systematic review, the platinum standard really of research, the highest level of credibility that we have for research, published in 2022, that stated that in the conclusion, the optimal concentration of nano-hydroxyapatite in dentifrices is 10%. So whether you are recommending Dr. Jens to your patients or you're recommending another nano-hydroxyapatite toothpaste, make sure that it's in the 10% concentrations. Likewise, it has to be in the nanoparticle size. As I mentioned, you're not going to get the same benefits for subsurface remineralization or hypersensitivity relief from a hydroxyapatite or a microhydroxyapatite crystal. Unfortunately, a micro or hydroxyapatite crystal is 1/5 the cost of a nano crystal. And for that reason, it is really symbolic for how patients, or how really I should say companies, have placed profit ahead of their patients' care. So unfortunately, nano-hydroxyapatite is symbolic for that decision that gets made. But really what I want to talk to you guys about the most is that synergistic relationship between nano-hydroxyapatite and fluoride. When you combine the supersaturation, really, of the calcium and phosphate from the nano-hydroxyapatite, that supplement of those minerals, it allows the fluoride to create more fluorapatite and remineralize the teeth. So what you're getting, and this was the conclusion to this 2017 study, was a synergistic effect between nano-hydroxyapatite and fluoride. Dr. Jen was inspired by that study, and she came out with the super paste, which contains the optimal concentrations of nano-hydroxyapatite at 10%, over-the-counter levels of fluoride, plus xylitol. And xylitol is great for reducing demineralization as well. So really triple the cavity protection in one tube of toothpaste. There were some companies out of Europe that were putting in these ingredients, but we weren't aware of anybody that was putting them in these ratios. So Dr. Jen had the super paste tested against a well-known high prescription 5,000 parts per million toothpaste. She had it tested in a simulated xerostomia environment. So worst of the worst conditions. It was done by a third-party lab called Therametric Technologies. They utilized the standard research methodologies for remineralization. And the results of that study were that the super paste outperformed the high prescription toothpaste by 6 times in terms of its remineralization capability. This makes sense though, right? When we know the mechanics of how fluoride works, we understand that fluoride is limited if it is in a xerostomia environment. So if it doesn't have that calcium and phosphate, then it's not going to perform as well as a toothpaste that has a steady dose of it. So that is a research study, but let's look at the clinical experience here. This is an email actually that I got from a hygienist just 2 weeks ago. They started carrying Dr. Jen's super paste in their office in January, recommended it to their patient in February here that has the bite wings. You can see the incipient lesions in February on 15 and 18. And then this patient wasn't able to come in for her restorative appointment. But she did continue to use the Dr. Jen super paste twice a day. 2 minutes each time, spitting, not rinsing, making sure that she was following all of the protocols behind Dr. Jen's toothpaste. And when she came back for her recare appointment in August, they decided to take these x-rays again, these bite wings. And I'll just read the last portion of it here. She said, "I was blown away at the new images. I wish I had a video of the doctor doing the exam, looking at number 18 on the radiograph, checking in the patient's mouth, going back to the radiograph, leaning back and pondering everything he knows about remineralization." Super fun. I just love that image of the dentist just pondering everything he knows. This is a testimonial as well from a dentist, an actual dentist out of California. If we can play this, Dr. Kroling.
All right, hi, I'm Dr. Rebecca from Huntington Beach. I've been a dentist for over 5 years now. I really like Dr. Jen's Super Paste. I use this on my sister. She really hates the dentist, so she does not like to see me. She lives in the Midwest, so I don't get to see her a lot because I'm out here in California. And she doesn't want me to drill on her teeth any more than I have to. She came to me for her 6-month checkup. She had some initial lesions, and I told her, well, you know what? Let's not go jump to any conclusions right now. Let's go ahead. I'm going to put you on the Super Paste. I want you to use this for 6 months. Next time that you come fly out to see me, we'll go ahead, we'll see, take some x-rays, and figure out, hey, are those lesions still there? Do we have to do some restorations, or do we not? She came back for her 6-month checkup. We took some new x-rays, and those lesions were gone. So I highly, highly recommend Dr. Jen's. It is amazing. Not only do they have the Super Paste, they have a fluoride-free version, and they have versions with fluoride. So definitely go get yourself some Dr. Jen's.
Great. Again, I want to say, we've made the best use of high prescription fluoride that we have, given what we knew about fluoride and how it worked. But now that we have these modern ingredients, nano-hydroxyapatite, xylitol, we know that a combination of these 3 ingredients really can outperform fluoride alone, specifically and especially for these patients that are suffering from xerostomia and a lack of that calcium and phosphate. We also make fluoride-free toothpaste for those patients that are immunocompromised or have been directed by their physician to not use fluoride. The strawberry is a great alternative for them. It can address symptoms like burning mouth syndrome. So definitely take a look at those as well. But the real story of the day is the Super Paste. This is the toothpaste that is replacing high prescription fluoride. It is redefining industry standards and really the protocol for how we treat these patients with high caries and with xerostomia. You saw the results there. It really is creating a benchmark now for preventative oral care products to aspire to. We'd love to get you the samples. I love that banner was up there the whole time. Hopefully you guys will click that, tap there, order some, or at least we actually don't expect you to order any right away. We want you guys to test it out and see what you think. Let us know if you have any constructive feedback. We'd love to hear that. Dr. Jen's is a nimble enough company that we can make changes to our products, and any positive feedback and testimonials, we'd love to hear those as well. We're getting testimonies almost weekly now. Thousands of offices all over the country are bringing in Dr. Jen's Super Paste and telling us the stories behind it, how these patients' lives are changed. And it's just really fun and exciting. So we have 7 more minutes, I see, on the clock to answer any questions that you guys may have.
I have them here for you here. First question, which I know you're going to love to answer. Is Dr. Jen toothpaste approved by the FDA?
Oh, yes. Sorry, it is not. But yes, Dr. Kroling, this is a question I love to answer because I would prefer that it was. I would love to see, and hopefully one day it will be recognized by the ADA as an anti-caries agent. And what we're seeing in because of that, as a consequence of that lack of approval and lack of guidance from the from the Food and Drug Administration as well, are these companies that are getting away with putting in diluted concentrations, ineffective particle sizes, yet able to make the claims that it's just as effective as fluoride. And so this is really, really sad, because it's our patients that are losing out with this lack of guidance.
So, Adam, just very briefly, tell us about the Wild West here, because the FDA isn't required to approve you, correct?
Correct. So because nano-hydroxyapatite is under the umbrella of a fluoride-free toothpaste, if it doesn't have fluoride, I want to clarify that because Dr. Jen's Super Paste does have fluoride in it, all of our toothpastes are actually made and manufactured in an FDA-regulated facility that upholds all of those safety standards and procedures. We use reverse osmosis water, things of that nature that the FDA requires. But for fluoride-free toothpaste, they do not have to be manufactured in an FDA-regulated facility. They don't have to list the types and concentrations on the tube of toothpaste. And so really what you're getting is a compromised product. And unfortunately,
Right.
The layman just doesn't have the information to make.
So it's important to find out, ask for transparency in the product that you're using or considering, and they should offer that up to you. Great, thanks, Adam. So there's another question here. What about toothpaste using both micro and nano crystals in the same paste?
Okay, so you want to make sure that the concentration of the nanoparticles is at 10%, because that's what the studies and the systematic review is. That mapped 28 different research articles, and it stated that the optimal concentrations are 10%. So you're really not going to get the equivalency to a fluoride toothpaste if the nanoparticles are less than 10%. So you really have to ask your patients, what do they want? A microcrystal just isn't gonna do the same thing. And so that's really what you have to look at. Companies that are putting in microcrystals, oftentimes what we're seeing are they're doing that to cut costs, or they're doing it to kind of aggrandize the overall concentration. A lot of clever marketing that's out there with hydroxyapatite right now.
Okay. Question here about xylitol. There are some negative effects of xylitol on blood clot formation risk. Understand that your body produces xylitol 5 to 15 grams a day. It's a normal byproduct or metabolite of carbohydrate metabolism. So the studies that were out there, especially the NIH, basically said in their conclusion, we need more studies. But go ahead, Adam, and add to that. I teach a course on xylitol, so that is one that comes up a lot.
Yeah, and similarly, the research that I've seen has not been applicable to toothpaste products. The concentrations or the amounts that were being used in those studies were much higher than any one person would get from a toothpaste product. And in Dr. Jen's, we recommend that you spit our toothpaste. We don't recommend that it is ingested. We want it to stay on the teeth, so don't rinse, but definitely spit that toothpaste out. And that's going to eliminate any kind of concerns that you would have about the xylitol effects.
Thanks, Adam. There's a question here. Can I get the x-rays pre and post nano-hydroxyapatite? And there's an email. Who is this? Amara, if you have a copy of this handout of Adam's in your course folder too. So, but we can certainly get that sent to you.
Yeah, those are cool x-rays.
Yeah. If we're a temporary dental hygienist and want to try this out first, so we don't have a routine dental office, is there still a dental professional pricing on this for us temp RDHs? Could not order this sample due to this as well. Thank you.
Well, that's a great question. We'd love to give you guys a sample if you guys are an independent hygienist. The fact that you are able to go into different offices is so powerful, and to be able to reach a lot of different audiences, that's huge. Whether we give the discounted prices, I know that is dependent on the bulk of the products, whether you order 12 or 24. So that part, why don't you reach out to us directly, and we can talk to you. Info at drjennatural.com.
There's a question here. Can these products help reduce root caries?
Yes, yeah. In fact, there is a 2011 study that looked at 7% nano-hydroxyapatite compared to 1,450 parts per million fluoride, and it showed that it was more effective than the fluoride toothpaste at addressing root caries. So because it is able to not only include those dental tubules, but adhere to the dentin itself, it can be extremely effective for those patients suffering from root caries.
Okay, we've got a few questions, but I want to make sure we get them because they're all great here. Can it be used on a 2 to 3-year-old?
Yeah, nano-hydroxyapatite, the European Union has deemed it safe to be used at any age. It does not induce any cell toxicity.
Okay, great. And what if a toothpaste claims to have hydroxyapatite, but it does not specifically say nano-hydroxyapatite?
Then it's more than likely microcrystal. So that's something you'd want to confirm with the company itself and ask them what size crystal. It needs to be 100 nanometers or less in order to be considered a nanoparticle.
Which one do you recommend for dry mouth?
For those patients that are suffering from dry mouth, the super paste, both in the mint flavor and the strawberry, are going to be the best for any patient that has a lack of saliva. Yeah.
This is a comment from Casey. I received samples yesterday after taking your class last week. Love the products and patient handouts too. Will definitely be recommending to my patients.
Great.
Great. Let's see here. Is there a nano-hydroxyapatite varnish?
There is not currently a nano-hydroxyapatite solely varnish. There are 1 or 2 companies that are claiming that they have a varnish, but to the definitions and specifications of what a varnish actually needs to do in order to be considered a varnish, namely it has to stay and adhere onto the tooth surface for an extended period of time, 4 to 6 hours at the bare minimum. And that requires a resin or a shellac. Unfortunately, right now, we do not know of a company that uses a resin or a shellac to adhere that. So really the best option is a toothpaste. There is a study showing that if you use a nano-hydroxyapatite toothpaste 10 days in a row, 2 times a day, that is as effective as a 5% varnish applied once. So continue to use the nano-hydroxyapatite toothpaste at 10%.
How much success have you had with decreasing sensitivity?
A lot of success. It's one of the most exciting ways that I am seeing results personally for myself with my patients that are coming back. You know, with caries, it's a little bit harder. You have to take those X-rays, and with hypersensitivity, you just get these patients that are coming back and saying, "Oh my gosh, I can drink ice water again. Thank you so much for that toothpaste." So.
Question here with ClinPro or RemPro, I recommend that a patient rinse with baking soda rinse prior to or include baking soda with the toothpaste when brushing to increase fluoride uptake. Is this necessary with Dr. Jen's toothpaste?
I'm not aware of that requirement. That's not something that I've seen any research on. You know, that said, baking soda can help neutralize the pH, so that could have an effect and help out. A mouthwash that has a neutralizing pH is a great idea. So whether it has specific benefits with nano-hydroxyapatite, I'm not aware of any studies.
Question or comment. Today I received samples for my pedo patients. Thank you. I want a sample for myself. Am I allowed another sample? Thank you for your presentation.
Sure. Yeah. Send us an email and we'll talk to you.
I'm a retired hygienist, but still sub. I'd like to order the free sample to try out. I like taking new information in my offices. For dental office, I listed substitute hygienist. Will this work?
Yes.
Okay.
Definitely.
Let's say, how long does it take to start having less sensitivity?
So the studies that we're aware of show results within as little as 7 days. There was one study that tested it against 2 other dental occluding agents, and the nano-hydroxyapatite outperformed those other agents, and it occluded 98% of the dental tubules within those 7 days. So you can use it, and some patients experience immediate relief. Others experience it a little later. I will say that it is imperative that the patients spit but do not rinse when they are using the nano-hydroxyapatite toothpaste in order to get those benefits.
Thank you. There is one more question here, and then I think we're going to adjourn. And the question is, what is the wholesale price point for offices without the coupon? Is that what you have on the screen right now?
Yes. So the wholesale prices are 40% off of the retail price, and that is what is available to you. And then for your first wholesale order, you get $100 off.
Okay. So everyone, you should have a copy of Adam's presentation in the course folder. If you don't reach out to us, we'll get it to you. And there are a few of you asking for second samples. What I would recommend is that you go to drjenoralcare.com or tap on that banner at the top of the screen, and you can reach them through their website. Anything you'd like to add, Adam, before we close? I want to tell you, thank you for an amazing presentation. You got me out of hot water, since I am not the nano-hydroxyapatite expert, but I am a believer.
That's right.
A believer.
Oh, it's such a pleasure. And it is really a joy to be able to speak to you all. If you would like to do a lunch and learn with us, Dr. Jen's husband, Peter, and we both love to speak to dental offices and get you guys on board with nano-hydroxyapatite, and also talk to you about the requirements for nano-hydroxyapatite to be effective, so that you then can be the experts for your patients when they ask you.
And how would they set that up, Peter? I'm sorry, Adam, with you.
Yeah, they could, when they log into request their samples, there's also a checkbox there to ask for a lunch and learn. So just click that checkbox and we'll get that.
And they get CE credit for that, I believe, too.
They do. You get 1 hour CE credit.
Yep. So take advantage of that. That's a great deal, and you can get your whole office involved.